Welcome to They've Been a Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Just wanted to come to you guys. We are starting something up. The goal is going to be just a weekly quick hitter time of clinical pearls. So I have brought on one fellow and one soon-to-be fellow that's in training. Lucas will also be joining us as well to really just rehash some kind of clinical things that you'll see and get some tips really going after what it is to get things better. So, yeah, our focus through this time is not going to be really going through thorough evaluation, everything there. We're going to assume you guys know that, and we may hit on a couple things regarding that, but what we want to do is just give you more tools and give you guys some things that you can be able to work with in the clinic. We're going to start with some different topics here through the time, but my hope is that we'll get to a point where people just start sending in on the physio channel things that maybe we can be able to talk a little bit about. So we want to keep it brief so you guys have time to be able to listen to it and get back to the things you're going to do. So please give feedback. Today's topic is going to be on periscapular pain. So everybody's had that patient that comes into the clinic. They've got kind of some dull periscapular pain, maybe upper trap, maybe rhomboid, maybe levator area. And really what we're looking at is we're going to assume that we've cleared out all our red and yellow flags here. So we believe it to be musculoskeletal in origin. From there, we just really want to hit on some things. What are you guys looking at, and what are maybe some pearls that you've been able to see treatment-wise regarding that? So let's start out with age first. Drew, fire away.
All right. So, my first thought whenever I see that kind of presentation, um, is I'm biased towards the spine, usually that lower CT junction. I see a lot of younger clinicians and myself for many years would go like, "Oh, rhomboid, stretch, do that." There's muscle tightness because that's a lot of times what those things will often feel like, and that's what patients will describe. But I'm telling you, don't go and needle the rhomboids like right away, like everyone always wants to. Uh, you're That'll make them feel better for a little bit. Uh, but I think if you're looking for like the clinical gold and you get the most bang for your buck, looking at that CT spine, and even sometimes I've seen where you're trying to, you think you've kind of ruled it out because you maybe have done some extension where you look up and you're trying to get some overpressure. But unless you really actually get into that CT junction, you might not hit it. So if you have them like retract and even that lower cervical spine extend from there and give overpressure, I would say 9 times out of 10, you're going to start reproducing their pain in that area. So if you want to get them better faster, that's where I would suggest starting.
All right, so we're really digging into making sure a good clear out of cervical spine, not just active range of motion, but maybe getting some good solid overpressure in those areas from the extension range. So cool. All right, Mark, what about you?
Yeah, so I'm gonna echo those thoughts in a lot of ways and just kind of add a little bit something extra, a different perspective. But a lot of times they'll even say that they feel a knot in between their shoulder blades, and they're like, "I just need to massage that knot out." Blah blah blah. Again, um, that's common and almost expected for them to say, and they'll feel a pulling sensation right there at that knot when they particularly look down or forward flex their cervical spine. And it can be a red herring, meaning that it is distracting you from what you actually need to get to, which is that cervicothoracic junction and lower cervical spine. Um, they can massage it all they want to. You can give them a tennis ball and have them do that, but don't waste your clinical time on it. Getting in and doing some CPAs and progressing to UPAs at that CTJ area. Think of it like you're almost milking out that chemical soup that's living in there. Um, and then that depending on sins, you can go with thoracic manipulations. Those are often a low risk, high reward, quick thing that you can do to have a large impact on uh, their pain symptoms. Uh, And then a lot of the research says from there, you got your repeated movements. So it's typically a discogenic presentation. And so repeated movements, retractions, really getting down to that CTJ. You can do thoracic repeated movements as well. But then to Drew's point, like when you're really trying to clean the corners, you may have to retract, extend. You may have to almost quadrant and repeated movement into quadrant to really flush out whatever else is remaining in there.
Yeah, that's where technique and screening and overpressures and all that is crucial because that is a difficult spot to clear. At least in my experience, this is probably why I have missed a lot of them as well. Because I'm like, oh, I think I cleared it. Definitely should be muscular, treat it, and then it's not. And you start looking at the spine again, and then they start getting better a whole lot faster.
Yeah. I think it's interesting too, as you guys are bringing this up, I'm thinking through, and it can look different for every person, right? And what we don't want to do is put so much pressure on ourselves that we've got to hit a home run in that one session, right? That we're constantly reassessing, we're constantly working through, our kind of evaluation component. And so I know that I've seen some people that, I kept thinking, all right, I believe this is coming from the cervical spine. I'm giving them chin tucks, but chin tucks aren't working, and you're trying to tease around. Is there a manual technique that I need to do to get chin tucks more effective there? Not that chin tucks are the gold standard in what you can only do, but, I have seen sometimes where, it was super acute and I had to maybe work on some soft tissue, or as you're talking about, Mark, some milking it and maybe give it a session or two and then coming back to those. And so not abandoning that, not abandoning when you've been able to reproduce from the cervical spine, that pain. Now, it's coming, there's a piece coming from there. And so we want to be able to make sure and rehash that. And I think so important as well that what we're giving people at home to do is reinforcing what we want to do. So any pearls for you guys on what you're giving folks at home for this?
Yeah, I'm gonna back up just a touch and in clinic, with some of the repeated movements for that area. It is kind of hard to get to with some chin tucks. I will fairly frequently take a patient so their head and like are just off the table is almost to their thoracic spine, so you can really guide them down into the chin tucks and extension, so you have a bit of a fulcrum there. That helps cue them to do that a little bit better, I think, than just straight chin tucks if they're having trouble doing that. But then at home, again, that's a tough one, Mark. I don't know if you have some other ideas, but one thing that I will often use is for that DT junction, if like the traction or retraction isn't working, have them come back and really squeeze shoulder blades and pull back as well, kind of in this position, elbows back. That seems to be pretty helpful for that upper thoracic CT junction for the repeated movement and getting some quick relief.
Yeah, more often than not, they're gonna need some form of extension to that area. That's a fine one there. I'll often do this position with their elbows on the wall and sliding up the wall. You're gonna get some thoracic spine, but it's targeted for like the upper thoracic. So hopefully getting more to that CTJ area. But at the end of the day, you want to match it to what they're feeling and using their symptom response as well as like how they feel with that movement, and then your test treat retest to really determine effectiveness.
I like that as well too, because they're gonna have a lot more comfortability when they've got their hands back there for both of you guys' techniques on the neck as well. Even kind of a relatively simple one that I've found. It's amazing how different a chin tuck can be in sitting versus if you cue them getting their head on the wall. Because now all of a sudden they can feel. I mean, we can say elongate the neck all day long, but motor morons are going to really struggle with that. So you get them on the wall, and all of a sudden now you see, okay, they're actually learning that kind of self distraction, taking the hands, and then you've got some other tools that you can be able to work with to get some impacts on this. So I think all those can be really helpful. All right, we got about 30 seconds left. Any fun takeaways here?
I think the biggest one is, again, think of these as how you're getting that patient out of pain, put the fire out, and then the key is doing a lot of strengthening, especially scapular strengthening overhead, making sure they're not throwing their chin forward, because that's where I see a lot of that happening, especially in the fit population. If they're doing overhead lifts, they just go overhead, head comes forward, and you start to get the pain in that area.
Yep, and maybe some activity modification, workspace, or, if they're frequently on their phone and just kind of sustained in this position. A lot of times you'll get people laying in bed with their head propped up like this and looking at their phone, and just kind of identifying those things that may set you back.
There you go. I appreciate it, guys. Yeah, I think those are all huge in terms of, obviously we want to make sure that um, you can treat symptoms. There's some benefit to that. Somebody's hurting here. Hey, yeah, give a little bit of love to the tissue there, but yeah, don't just go stabbing needles in there and tennis ball and expect it to change. Let's really evaluate and make sure we're using our tools to get after the root causes there. So,
All right.
good
So
stuff.
say I
Yeah.
identify I know my bias, but I'm biased there for this
Yeah.
practice pattern because I'm usually right. And it usually works better.
There you go. You heard it from Drew here first. So, um, no, awesome stuff. All right, that's our 8 minutes. What we're gonna try and do is keep the answer times to 8 minutes, since we all love our 8-minute rule. But we're gonna wrap up there. Look forward to we're gonna be consistent with this, so we want to have something coming out for you guys every Tuesday morning. Again, feel free to send in any things that you guys want us to talk on here, and I will ask the experts here. So appreciate you guys. Have an awesome day.
Thank you.